mission here is to maximize the capacity of high-risk organizations to achieve safer outcome. Today's session is titled Quality and AI, Ensuring Safety in the Age of Artificial Intelligence. As AI continues to evolve, it's essential that we understand how to apply it responsibly while ensuring the quality and safety of the technology. We're very fortunate to have my dear friend, former classmate and fellow Navy veteran, Dr. Richard Greenhill with us today. Rich is the principal and founder of Smart Sigma AI and an internationally recognized leader in healthcare quality and patient safety. He serves as the editor-in-chief of the International Journal of Quality in Healthcare Communications and is a member of the ISQA Academy. With more than 30 years of leadership experience, he advises organizations on AI governance, quality improvement, patient safety, and operational excellence. A quick reminder, today's session is, as Riley mentioned, is being recorded, and you can submit your questions anytime through the Q&A feature. We'll make sure we save plenty of time after the presentation for your questions. With that, let me turn it over to my friend, colleague, Dr. Greenhill. Rich.
Good afternoon, morning, everybody. I'm here in Texas, so I'm going to turn my camera off because it distracts me, and then I'll be back when we have our Q&A. So it's a pleasure to be here. I'm going to share my slides here, and then we'll have a conversation, and hopefully this will inspire you to have some questions and so forth. Let me share here. Tech person here, so I'm supposed to know how to do this, right? All right. Can y'all see my slides here? Let's see.
Yes. Yes, we can, Rich.
See everything there?
Yep.
All right. So again, it's a pleasure to be here. Thank you, Steve, for having me and to your team here. Over the next 30 minutes, I want to really talk to us about something you can actually use and see. All of us that are associated and interested in patient safety, we know the risk that can happen when, processes are not planned properly and those kinds of things. So I'm going to talk about artificial intelligence from the perspective of AI, and let's see if any of this resonates with you. So I want you to take a moment and just look at the top of this here, and you want to think about the most experienced person on your team, and are they still there? Now, the reason I ask this question, and if you're in the DoD or government, it may be different, but a lot of people are being laid off, right? So I posed this question on a newsletter that I have, when we think about artificial intelligence, what I'm seeing right now around the world, as I travel and speak to people and work with health systems, is that everyone is trying to achieve productivity gains through using AI. That's a great thing, right? It's good to, work on, physicians being burnt out and improving workflows. But when we cut too deep, when we cut too deep and we lay people off, what happens at 2 a.m., for example, when something doesn't feel right, and then the person that you look to that had that knowledge is gone? So this is really, in my mind, sort of a side piece to all the efficiencies that we're going to gain through artificial intelligence. And truthfully, there are some, right? Ambient documentation is great. And so we have to think about that. So, let's think about where we are today. So I want to level set us here on where AI is actually right now, just in general, because the speed of what's happening, is really the context for everything else I'm going to talk to you about today. So roughly, 80% of healthcare systems have AI or some type of tool operating in at least one of their clinical departments. And so when you look at the global market, there's some numbers I saw that say it's upwards of $45 billion. Now, this is not a pilot program. This is already in operations across the care continuum. And yet 4 in 5 clinicians have concerns about safety, bias, or reliability. I was speaking to a group of physicians a couple of months ago down in Houston at an event, and they're all concerned that they're having, People are using AI and they don't know if it's valid. I mean, that's a problem for them, especially when their license is concerned. And they're also worried about their patients and making the right decision. Where was the data trained that's making these decisions inside of the electronic record? And so that's a real threat. And I'm going to talk to you about something very exciting at the end today that my organization has put together to think about this. So some of these trend areas at the bottom here are really where I focus when working with executives. So ambient documentation is pretty mainstream right now. AI diagnostics are moving from pilots to standards of care. We see that. And predictive deterioration tools are proven but require constant monitoring. So at the end, the exciting thing I'm going to share with you is something that we're coming out with tomorrow, actually, a post-deployment tool that for monitoring. We also see something like autonomous agents, something around autonomous agents that are challenging. They're good in some places. There's some threats to them, and so these agents are making decisions. You know, sequential decisions really, and they're entering the sort of processes faster than most governance frameworks can handle it. So the speed is not the problem; it's the lack of preparation for failure that I perceive is. So the other thing about autonomous agents that's different from predictive AI that I'm used to programming in and generative AI is that these tools make decisions. These agents make decisions. So that's first. So who's controlling them learning and continuing to make decisions? I mean, it's a real something really to pause and think about. And think about if you have something we call data poisoning, and when generative AI learns from something it produced, that's not real, right? So, and then there's another concept called grounded truth, where what is really the truth when things change all the time in healthcare, right? Standards change and those kinds of things. So we have some real concerns for patient safety that we need to think about. And so I wanted to just frame that here as we go forward here. So, you know, this is the patient safety conversation that isn't happening, in most boardrooms. And I kind of mentioned earlier, and this is something that needs to happen. So, the business case for a lot of AI in many of our healthcare systems around the country, at its core, is a headcount reduction argument. Last week, I was at the National Congress for the American College of Healthcare Executives and spoke about this and other things, related to, AI. And the decisions that people make to reduce staff, right, using AI or some other technology, these things are not things that people are doing carelessly. They reflect, real fiscal pressure. I mean, we see that, right? And reasonable confidence in the technology. As a data scientist, I'm a little more skeptical than a lot of people, and also a quality person. I'm very skeptical, but good faith is not the same as sound governance, particularly when you're concerned about patients being harmed. So at this point, when we decide to eliminate the experienced professionals who understand how care is delivered before it was automated, we're not reducing redundancy. We're removing absorptive capacity, really, the shock absorbers, right, that keep patients safe when systems fail. So let me ask you a question. We've all worked in hospitals or been adjacent to them. What happens when you have downtime or you have a system go down or it gets hacked or ransomware or electricity failure or you name it, and the AI systems go down and you've laid off all the people or reduced the staff and gotten rid of those areas of expertise? And now what do? This is a real patient safety concern that I think we all need to think about. And like the slide here says, it really is about you're getting rid of institutional memory and really that deep experience that we need to really make sure our patients are safe. And so it's kind of a through line for everything we're going to continue to chat about today. So, you know, in the description, of the seminar today, it really called out data integrity, and I want to give this the weight it deserves because it's probably the most underappreciated patient safety variable in AI implementation. And so you've heard the adage, garbage in, garbage out. And this is not just a tech thing. In healthcare, it's a patient safety principle, in my opinion. When the data that we're feeding our clinical AI is fragmented, which most of it is, biased, which most of it is, or incomplete, which most of it is, the outputs cause harm while appearing authoritative. So I tell people when they're thinking about AI to think about it in sort of concentric circles. This concentric circle that's the most risky is dealing with anything clinical that's making decisions or coaching physicians or talk to physicians and nurses about the care they give. There's another layer outside of it that's sort of the check-in process, right? And all that kind of stuff. And then the most outer layer are things that don't touch the patient. So the places in healthcare right now that me personally, I think are the best are those places that don't touch patients, right? Maybe you used it for prior auth, revenue cycles, supply chain, those kinds of things. But when you get to things that are patient facing, that's when the danger comes. So with that, there are three imperatives here that I've listed. And so the first is around governance and who is accountable for what goes into your systems. This is really a board level patient safety obligation, and it's not an IT project. So it's fair to remember that. And so integrity is really about our data completeness and accuracy. So, EHR fragmentation is the hidden risk that most organizations aren't talking about at the right level. I can tell you years ago when I ran a big program for a 9 hospital system in a certain part of the country, trying to deal with the quality indicators long before AI, right, was a challenge. So how are these people now? And it's a rhetorical question. And each EHR was on a different version. So how are we now able to plug AI into this and to make that work? That is a real challenge as it relates to data integrity. And a lot of systems around the country are this way. And then last is just bias review. And so if you're training data, the data that you tune your algorithms on reflects historical disparities, your AI is going to really replicate those things and to scale, right? And scale those. And that's an equity issue and a patient safety issue and so forth. So I've watched a lot of organizations, a lot of them are deploying really great AI tools on top of deeply compromised data. And, the results look clean on a dashboard, and the harm is invisible until it isn't. And again, the kind of surprise at the end is not surprise, but just this new framework that we've created is going to answer some of that. So let me walk through the 6 risk categories that every patient safety professional and quality person needs to really understand. So I kind of split these into 2 slides so you can read them clearly on your screen. But model drift is the one that concerns me the most. This is invisible. And so as a data scientist, when I think about the other industries that have dealt with this, and this will be documented in the executive brief that's coming out tomorrow from our company, other aviation, the nuclear industry, manufacturing have dealt with this, square on, and which is why those systems are safer. So dashboard shows green, and the accuracy has eroded because the patient population patterns have shifted, right? Degraded outputs are shaping now the clinical decisions before anyone realizes that something is wrong. There's not an alarm that goes off from model drift. You have to anticipate that, once you've deployed a system to recognize it. And then there's alert fatigue, really, which we've seen, prior to AI. And this is not the same, though, as traditional alarm fatigue. The volume potential for AI fatigue is dramatically higher. And I'm not being dramatic saying that. If your AI generates 400 alerts per physician or clinician per shift and 380 are noise, you have engineered a system that trains people to ignore warnings. And we talk about all the time in certain meetings, I'm in risk meetings, who's responsible if the AI makes a decision that the provider says, I'm going to ignore versus I'm going to follow, right? There's licensure concerns there. And I don't know that I haven't seen a case yet in the law where a provider has been accused. And I think the first time that happens, it's going to change a lot of things for us. And the last year is algorithmic bias. And so, again, if your AI performs well on certain populations and poorly on others, you have a real patient safety disparity. You want to make sure you test across subgroups, race, gender, age, and socioeconomic status and all that. It's really not a negotiable thing. There's a great study out there from 2019. I think it's Obermeyer. I'm probably saying the name wrong, where they looked at data for care coordination. It's one of the most cited studies for AI bias. So I would challenge you to take a look at that if you're interested in knowing more. It is far more pervasive than we realize. And then here, the last three here are automation complacency. And this is probably the most insidious cultural risk. So when staff stop questioning the algorithm, safety culture is already degrading at that moment. And so I'll talk a little bit more about this on the next slide. But cybersecurity exposure is a big one. This is something that I've done some publications on, and healthcare systems right now are the number one cyber attack target. You hear it all over the country, right? A big health system I worked for years ago in San Diego was ground to a halt because they were attacked. Some of these AI systems have holes in them, and you can have bad actors go through medical devices and do all kinds of things to through AI, through the AI portals and those connections. I'm not an IT guy. I'm a data scientist, but I do understand some of that. So when an AI system goes dark, though, in a clinical attack, when an attack, that's a clinical continuity event and not just an IT ticket problem, right? And then accountability gaps. When AI contributes to an adverse event, do you have a clear structure in your governance? Who's responsible? And if not, that gap needs to close today. I'll also say that the Joint Commission is working on some stuff with CHI. NIST has put out a framework and some other things. And URAC, it's a accreditor out of the DC area. They've put out some standards around governance, but governance is the most important thing as it relates to managing artificial intelligence for patient safety. You have to have board visibility, and the leadership team has to understand what's happening in order to support the patient safety apparatus here. In 2022, I was one of 19 experts convened by the WHO in the Middle East to advise on hospital resilience. And so this links to patient safety in AI because there's two types of resilience, right? Hard resilience and soft resilience. So resilience is when people can actually see things like infrastructure, technology, and so forth. You can see things. The soft resilience is really around the institutional memory and human competencies and the things that allow organizations to function when everything else fails. When I mentioned earlier the failure from laying people off, this is where that comes in. So there's a part of the institution that lives in the people, right? It's not just machines. We're in the business of healthcare. So in order to keep patients safe, that nuance and intuition is as important as the data is, in my opinion. So, most of our boards have great sight into the hard resilience, but soft resilience is less visible. And that, in my opinion, is where patient safety risk accumulates the most. So a cultural dimension that I really want to name clearly is that patient safety really, and the culture of patient safety degrades when people believe the system is infallible. I know our leader here, Steve, flew airplanes, so I'm sure he didn't trust always what his controls were telling him, and he had a certain insight around what was happening, and that allowed him to challenge what the system said. And I don't know, Steve, if there were times that the system said one thing, but your intuition and experience said something else, and it made a difference. I think that is really true in healthcare because the machine can't look at a patient and maybe see sepsis. They can look at things and at the data that's being captured, but they can't look at their face to see that maybe their pallor has changed or that they're sweating, and so forth. And again, I don't know that I would trust that personally for myself or for my family. So we'll get practical here. And so I use this kind of framework, my company does, as we're helping people roll out artificial intelligence. So I'll share it with you. The first thing we do is I'll obviously go through and work on, can AI even help here? Is it even, relevant? A lot of people, that I see around the country are using AI for something they could just use a spreadsheet for. I mean, spreadsheets aren't great either anymore, right? But I'm saying it to mean that they can use a less robust tool. You don't have to use AI for everything, but I think in the arms race for AI, everyone is trying to, okay, we're using AI, right? I'm going to go tell my board we're using AI. Well, you want to use the most appropriate product. And so and make sure it aligns with what your mission is. So then we look at evaluation with rigor. And so we ask vendors for peer review evidence and not vendor demos, because the vendor demos are sometimes, fabricated. And again, I'm a consultant, so I get it. I'm not a vendor for AI tools, but published validation studies are really the way to go as it relates to this. And so that people can make informed decisions and think about patient safety in the context of what their operations are. Pilot kind of it can be an ugly word sometimes, but pilots are important. I believed in it. I'm a master black belt in Six Sigma, so I believe in piloting. Always have. It's true here. But a lot of times in healthcare, what I see is we pilot, but we just keep going. We go from pilot to implementation without stopping to really see, did it work? And pilot, engage people, and make sure that we iterate, to get the system where we need it to be. And then there's integrated monitor. So, we mean that we want the people that use the technology to have a say. And, integration is where most AI fails, and not technically, but operationally. I mean, we have to have people on board and bring people along and not do something to them, but have them be part of this process. I can't believe after 34 years, we're still having people go in and, this people in the C-suite know better than everybody else. That is absolutely not true. We need to go to the front line, to the Gemba, and ask people, and this is really around safety, right? Who knows better than that nurse or physician or technician at the front line about the safety of their patients? They know better than the people sitting in the ivory tower. And I'll say that until as long as I work in this field. So, and then you got to monitor. I mean, it's AI is not like other things that we do in healthcare. You can't just set it up and forget it. Model drift is a real thing, and alert burden is a real thing. And we have to surveil those things in our quality program. I almost believe that we need a whole separate line of monitoring for AI in the quality apparatus. So that's my opinion, though. And then the two boxes at the bottom here are, train people when not to follow the AI, and you always want to start with the clinical need. Our digital literacy has to come up, right? We have to train people and not just tell them to trust the system or tell them nothing, right? I go back to Steve because I like to fly too. I have all the flight simulators. So I bet Steve kind of knows when to use the autopilot and when not to, right? He just doesn't trust that those he has the knowledge of planes, right, to understand what's happening. We have to do the same with our patient safety folks. So Steve, I'm using you quite a bit today because I like airplanes. So so here we think about the continuity and who's accountable. This is very important. When something goes wrong, who do we turn to? And I think that we'll see in what CMS and some of the regulators are going to tell us is that the person accountable is the care team. It's not the vendor. It's not the AI, right? At the end of the day, if you look at what CMS has put out already about their guidance, they say that the clinician has the final say. That is good for patient safety. But it is only good when the clinician knows when to trust versus not to trust the artificial intelligence or whatever it's telling them. So I think we also have to think about, and our boards have to think about, what human expertise do we have to keep, right? Irrespective of how many people that we can lay off or repurpose, right? If the goal is efficiency over and money over patient safety, then this is going to all come crashing down at some point. The patients are the center of what we're here for, not efficiency, not margin. You do have to keep the doors open, right? No money, no honey. But it's really about the patient. And so we have to keep that in the middle of our forethought in as we go through Patient Safety Week here. And so, this is sort of the end here. AI is not going to protect our patients. It's going to be our leadership and our governance structures. And then I want to share with you all that turn my camera on here. Hopefully you've had lunch so I don't make you lose your lunch. But so what I'll tell you here is that we tomorrow, Smart Sigma AI will, and we'll get this document over if you're interested. We're going to release a new taxonomy and classification framework and a logic model for post-deployment recognition of AI model degradation. And this is all around patient safety and AI use in clinical settings. So we're very excited about that. I thought I had a slide on here that I tacked onto the end, but in my old age, I might have missed it. But the goal is for us all to think about that AI algorithms degrade in silence. It's not like an alarm or you don't see it until it's a patient safety event or a sentinel event. And so this framework and white paper we're releasing tomorrow is going to highlight that. And so I hope you all will be interested in seeing that, because it's going to help you think you and your leaders and boards think at a different level about the risk that we are kind of unaware of. We know that we need to monitor these algorithms, but we don't really know what we should be monitoring and what we should be paying attention to. So this taxonomy and framework is going to lay that out. So with that, I think I'm at 11:30. So right on time, Steve and Riley.
Well, Rich, thank you very much. I'm going to definitely put my hand clap in there for that. So thank you. It's a great presentation. It's really kind of helping us ground us in this topic. It's a great topic for the time we live in right now as things start to accelerate, continue to accelerate. We have a lot of patient safety professionals on this call, as you know, and I'm going to kind of start there. It was interesting. I'm going to kind of start from the end, sort of first of all, I think the taxonomy could be really helpful for us. So understanding what we should be even kind of framing, how we should frame the challenge, right? I think that's going to be really interesting. So I'm going to be really interesting to see what you all are coming out with. There isn't, a tremendous amount of guidance out there. We've seen some organizations that are interested in the safety of the AI, but we're not. I don't think with any of the AI we've seen, even our personal use of AI, so forth, that we're able to kind of almost be able to keep up with the safety and quality aspects of what we're being delivered currently now. So I think you raised some of those topics, but how important that is a different area in the administration of healthcare and services delivery of healthcare. So here's what I'm thinking. Your patients are going to, like a lot of things in patient safety, I think anybody on the call will really sort of resonate with them, is they're probably going to assume that the healthcare organization is already doing this if they're using AI. I mean, have you run into that, like that the things you're talking about to ensure the safety of the AI, that patients are going to assume that. And so again, that trust that you've built with your patients could be in jeopardy. Any comment on that? It's not really a question. It's just sort of an observation based on when you talked about the patient-centeredness of this.
Yeah, it's interesting, Steve. I said this to a room of probably a few hundred people at ACG, and I got kind of a gasp. I think that people assume, well, first of all, I ask my colleagues who are rolling these things out, how have you consented your patients? First of all, because, informed consent, you have to tell patients what you're doing to them, why you're doing it, if you come up with a result, how you got there. My clinician uses AI, and I actually asked them, are you using AI in the record? They say yes. I was like, where's my consent? And of course, they get scared because they don't work in healthcare. But I don't know that. So number one, I don't know that everybody is telling their patients, and the patients are blindly trusting. And this is based on my own experience, and I get some care at different facilities. I won't name one on here because, but I think people are trusting, and I think right now what's happening, Steve, is a lot of facilities are vendor dependent, right? If you have an Epic EHR, and I'm not bashing Epic, are they really going to let you in on their proprietary processes around if those models if they're degraded? I'm not just talking uptime. I'm talking, is the model still performing like it was when you validated when you validate it initially and the last validation, I mean, there's a specific set of metrics that should be being reported to the leadership. So I think a lot of patients are blindly trusting. I think a lot of providers, some of them that I spoke to last fall, didn't even know that there was AI in their system. I mean, they assume it, but they get these reminders and things. And in my opinion, anytime you're touching anything to do with a patient and you're advising providers, everybody has to know, because my question always is, what data did you train, these tools on? That is the number one question that I teach providers to ask. What population, what parameters? And a lot of the ones I've spoken to, they don't know. They don't even know what to ask. So I think it's fair to say that if I had to make a generalization, that a lot of patients are just blindly trusting. We haven't taught patients how to ask about AI. They go in and, we just assume that the doctor and nurses know what they're doing. And, we put our lives in their hands. I think that there's a side of this, though, around patient-centeredness that I think we need to teach patients about medical AI and what to ask, in an accessible way. We ain't gonna, they're not going to make them data scientists or doctors in health administration, but we should have almost like an AI patient rights and responsibilities, where they get to understand what it is being done to them, and we prime them with the questions to ask to keep themselves safe. I mean, I feel like they need a bill of rights, I guess, if you will.
Yeah, that's awesome. Awesome. Yeah. And that was also in your comments about we may not have the right measures either for understanding the safety of our AI. And I think you broached that also in the topic of how safe is our data, because you talked about data integrity, data quality, about how these models are being used. And oftentimes we make assumptions about our data quality and our data integrity. So thank you for also bringing that up as a risk too, and part of what we're going to have to manage. One comment is also in there with our question about that in fact are places where we've seen error rates actually go up with AI usage, and that's the business we're in, is dealing with errors, right, in the patient safety realm. So again, especially when you're in the referral area and insurance companies maybe start, or other payers are starting to use the AI to try to understand how to best serve a patient. But any comments on that, on kind of working upstream a little bit with other parts of the system, like payers?
Yeah, I haven't done a lot of that work. I don't want to demonize them, but I will say that when I think of AI, I look at the business model. The business model of insurance is, and let me just say, this is Rich Greenhill's opinion, it's not patient safety. It's saving money, right? So I almost feel like we're the defenders of the patient, those of us doing this, because a lot of times, and I've seen some reports, anecdotal reports on the news, that people were denied certain cancer treatment that they needed. And there's a question, well, did AI help with that? Right? If the cost is more, then, how when they diagnose people and they say, well, here's your prognosis. I don't know if they're being ethical with their AI. Are they focused on cost? If they are, if my cancer care costs 500 grand over the next month, and my prognosis is I might not only live, I have a 20% chance of living, you know what I'm saying? I mean, there's an ethical question for me, and I don't have the answer. I think in some of the work that I have done early, maybe a few years ago, with some one insurance company, they were focused just on revenue. They care about the patients, and of course, that's their front-facing language. But at the end of the day, it's about saving money, and that's what I saw just on the periphery. I was helping them build dashboards. I wasn't in the actuary part, but it was clear what their business model was. It was it wasn't making sure that patients get the care they need, especially if it's really expensive. They tried to find ways not to fund it. So unfortunately.
Donnie brought up a point about at what point, will we need to think about informed consent when it comes to the use of AI? I know AI is already being used, say, in the medical device industry, right? In a lot of our medical devices. But at what point will that need to be maybe more explicit, do you think, as you add in the how we might change some of our policies and governance?
It's a good question. I did a talk in December to some compliance folks. It's out there online, but CMS requires us to consent people, right? So I don't mind sharing. I have something called supraventricular tachycardia, right? It's a heart condition where my heart does some funny things at different times. Well, they had me wearing a Holter monitor. So when I saw my cardiologist, I asked her, and I know there's AI in the system because I have biomedical friends. I said, okay, you're using this Holter monitor. I'm wearing it. It's transmitting. So are you using, and it said in the package insert that there was AI in it. So I asked her, I was like, so are you going to consent me on this? And she said, well, that's the medical device's problem. It's not my problem. I was like, that's not true. You are taking care of me. You recommended this. And she just looked at me with a blind stare. She had no idea what I was talking about. This is about a year ago. So I think there is that this is going to be a problem. And I'll say this is my opinion. Unfortunately, it's going to take someone to get harmed, go to court, and it's going to all get flushed out there. And that's when there's going to be a real knee-jerk reaction to make things change. Because right now, people are just sort of moving with the flow. Well, okay, the vendor took care of that. The vendor, though, is not my physician. You're my physician, and you're supposed to be telling me, so how do I know that? And then it's funny, Steve and group, I asked her for my results. She said, well, you have to talk to the company about that. I'm like, well, is this supposed to be my record? I mean, so there's a question right now of who owns the data. And that's
Right.
sort of the thing that, they're like hands off. So I think it's going to be a problem. I don't know that I have an answer for it, but I think there's going to be unfortunately an event, and that's going to cause, the rules to get more strict.
I think, there's a theme that, and definitely a message that you're sharing with everyone on this call, and that it seems to be so important, which is healthcare organizations, our hospitals, clinics, those, that are delivering the healthcare to our patients, can't delegate patient safety to their vendors. They are responsible for patient safety, and all the way down to the bedside teams. But all of us who support those teams are responsible for the safety of our patients. And I think that's a really strong message, because we really aren't going to be able to count on our vendors. We want them to be involved with us, and it just says that there's a new line similar to where we've probably been on our health IT journey, since going digital. So great point. What about for the patient, safety professional? I'm thinking more in the area of like upskilling. If you're a patient safety professional, where I mean, it seems like we're going to have to do a whole lot of upskilling ourselves in the AI area, because of we're kind of used to alert fatigue. That's something we've been dealing with in patient safety for a while, and thinking about how to solve for that. But it looks like that's not going away, number one, with AI. The other two, though, model drift and algorithmic bias, those feel like really hard things. I mean, we're not trained, as patient safety professionals in those areas per se. So it sounds like to me there's probably some upskilling that's going to have to happen with those of us that are going to be charged with making these technology, or helping to make these technologies safer for use.
I agree with you, Steve. And, I think I would say the opposite. I think that you all and we, because I came from this world, like we are trained, we're probably, and I made this comment at a talk I gave in Brazil a few months ago, that patient safety staff, Six Sigma folks, we are really the people that, because guess what? We're already trained in statistical process control. We're trained in data analytics. So the reason that my career shifted from quality and data analytics into purely data science is because I had the foundation. So I think that we naturally already understand measures and values and those kinds of things, rates, right, of infection, those kinds of things. So I think we're primed. It's just really about getting the right education. And I tell people I'm not anti-Harvard or Wharton and all that. If you want to go to their class, go to it. But I think we have to focus more on the practical use and not the pie in the sky stuff around AI. Like really, I like Udemy. I mean, and I think it's been bought by Coursera. They have free courses you can take, so that's a great place to go. and really just learn about AI. There's not a lot of courses though. We have one, ACHE here in my company, we partner and we have a course, but there's others out there, but there's very few though that will take healthcare and AI and put it together for the person
Right.
that's practicing. It's all the pie in the sky stuff and all that, which is great conceptually, but if you're trying to know how to use it, there are courses through Udemy and Coursera you can look at, or ACHE, or I don't know
Yeah.
if NACU has anything, but
So yeah, so I think that's really encouraging, right? There's a little bit of what you're adding is that if we're doing, say, for instance, we're putting together an RCA team, right? After an event that we believe has an AI component, we just need someone on the team that maybe will help us with some of those kind of more subject matter expertise kind of levels, like we would do with any sort of investigation, is what
right.
you're saying. Yeah.
Yeah, right.
So, and then we also, again, a lot of us are taking, as a human factors engineer, we're also seeing some more emphasis on human factors in healthcare and certification around those areas. And so you're saying that some of our existing certifications and where we're getting, continuing up the professional development scale will serve us well as generalized skills to manage this new hazard or threat to safety.
I think so. I think the AI piece is tough because it can either be very technical or very pie in the sky. Bridging it to be where you have teach us to be translators is tough to do because there are very few people that have both sets of experience. You have technicians trying to train people, and then you have the pie in the sky people trying to tell us what we should be doing. But that nuts and bolts stuff, I think we can get through, things like Udemy and Coursera.
Yeah, and I think going along with the human element of this is the human oversight, just like you said, that we can serve as that human oversight or the human eyes on the AI technology as well, and how we do that within our auditing and feedback frameworks is going to be super important. I know we're coming up on time. We got about a minute left, and I want to say thank you so much, for this time together. It's always great getting back together and talking about the topics like this, and especially ones that are emerging like this. And you always seem to be on the forefront of that, from the data science perspective, the analytics, all important. I do have one more question that I
Sure.
would say, and it's really about we are always so thankful for people who report patient safety events, near misses, adverse events, and that's part of that just culture element that we all promoting in the safety culture promotion. You brought that in. Thank you for that. And again, all I want to say is with that is how are we going to even help our reporters report events when they're not really aware of, like you said, some of the AI background that is involved potentially in a near miss, for instance. And I don't know if you have an answer for that, but I'd love to hear your thoughts on that as well.
Sure, I do. It's a big gap, Steve. You almost need an adjacent, in my opinion, AI sort of event because the events are different. They're silent, which is part of the name of our what we're going to release. But there's so number one, we got to train people on what to look for. Number two, we have to have the governance to be able to manage when we find it, what to do and think about prevention. The other thing, which is more fundamental, is we have to ensure we go back to that just culture because right now we're struggling with quality in people reporting events. What's going to happen if AI makes a decision I followed, I'm a physician, and it turns out to be wrong? Am I really going to report myself? So we haven't created the safe environment in general. And now we're adding another layer of technology that is potentially more dangerous. So those are the three things. We have to first make sure that we focus on just culture. It's there. Then we have to train our quality people and our staff on what to look for, how to report, and so forth. And then overarchingly have the governance to even mitigate, prevent, and deal with issues as they come up. So there's really three areas, and right now it's a huge gap and opportunity as well. So
Awesome. Thank you, Dr. Greenhill, and over to you, Riley.